So, first things first, I'm just gonna have you guys both introduce yourselves. Either one of you can go first. It's up to you guys.
Well, I can go first.
Go ahead, Jen.
Um, my name's Jen Gummer. I am the lab supervisor here at Bozeman Health, but I am a clinical lab scientist. Um, I have I graduated with a double major in biology and chemistry, and the school I went to, which was a small liberal arts school, anytime you were going to go into anything professional, pre-professional, anything, you needed to do kind of a shadowing program so that you didn't decide you wanted to be a dentist but had no idea what a dentist does, which I think happens to a lot of people. So I would encourage anybody to shadow someone for sure. Because I loved chemistry, I thought lab definitely back then, which was a couple of years ago, it definitely was not as automated and it really was more like a chemistry lab. And I found that to be very, very interesting. Um, my other pathway, I really wanted to go to med school, and good or bad, I shadowed a family doctor who, once again, this was a long time ago, but he did general surgery, delivered babies. He literally was never home, ever,
Mhm.
ever. He went to the office and then he was never home. And that was not a life that I wanted. Um, I also did not know that pathology existed. So if I would have known that, I might have found that more interesting than working 20 hours a day. So that's I've been in Bozeman since 1987.
Wow.
So I've worked with Bozeman Health since 1987, working all shifts and then um, becoming a supervisor.
Mhm.
My turn.
Mhm.
So my name is Nick Bloom. I'm a physician specializing in pathology. I work in a community pathology group called Yellowstone Pathology. We're split between Billings and Bozeman. So I'm here with two partners, and we take care of the work at Bozeman Health and some of the small surrounding hospitals. Um, I had a fairly long and convoluted training pipeline, which is kind of unusual. So students who are aspiring to be physicians don't have to do what I did, but I graduated from a small college with a Bachelor of Arts degree in religious studies. Um, I kind of came to the conclusion far too late, but right before graduating, that my true calling was to be a physician. I thought I wanted to do family medicine. So I actually had to go back to school and do all of my pre-med coursework after I achieved my bachelor's degree as sort of a post-baccalaureate. I spent a few years working in outpatient mental health in a refugee program up in Portland, Oregon, until I got accepted at Oregon Health Sciences University. And like I said, I still wanted to do family medicine when I started. I signed up for a military health professions scholarship in the Navy. So I realized that it is pretty burdensome, the amount of debt that you take on to go to medical school. And at the time, I had a friend who was already in the Navy as a med student, and so I got a kind of all expenses paid trip to San Diego to go to the hospital and meet with Navy docs and tour some of the ships and other facilities to see what it would be like to be a Navy medical officer, which I thought was awesome. So I said, I'm going to do this. So I signed up for that. During medical school, I kind of changed my interests, and I thought halfway through I was going to go into general surgery. And during that time, I was also I did what's called a post-sophomore fellowship year in pathology, which some medical schools offer. It's kind of like an additional year that you can sort of take during the course of your 4 years of medical school. And it was really during that year that pathology was not something that I had even thought or considered. I think I had this vague notion of pathologists just being, kind of in the hospital basement doing postmortem exams all the time. But the pathologists I met were fantastic, and I realized my real interest was in disease. I was not so much interested in clinical medicine, like how to treat patients, like I thought I was. I was more interested in actually the visual side of making a diagnosis through the microscope. So knowing that I was going to do this, I still had to pay back the military for my scholarship. So I finished medical school. I did a year as an intern in general surgery, and then I did 3 years active duty as a undersea medical officer. So I was trained in hyperbaric medicine, and I worked with submariners at a submarine shipyard in New Hampshire. So once I decided not to make a career out of the military, and so I resigned my commission after I was done with my service commitment and did my residency in anatomic and clinical pathology at the University of Utah in Salt Lake City with a fellowship year in hematopathology. So I subspecialized in diseases of the blood, bone marrow, and lymph nodes. So that's what heme path, as I call it for short, is. I took a job with this group straight out of training 7 years ago, and I've been here ever since. So it took a while to get here, but I am glad to be here. I do enjoy my job, but it is challenging. We can talk about pros and cons in a minute or whenever you're ready,
Yeah.
Jeff.
Um, just the first thing after that I wanted to do, just so like, because I mean, I've done a little background research, so I have a kind of a general understanding of pathology and clinical lab science, but just so that the listeners and the viewers of this kind of have a better understanding, can you guys both like explain a little bit about what the career of what your guys' careers like clinical lab career and pathology both entail? Like what are the responsibilities? What do you guys kind of day-to-day lives look like? What's a day in the life of you guys? Jen-
Well, as a clinical lab scientist, our our lab is open 24 hours a day. So obviously people can work many different shifts. We are responsible for instrumentation. So we work with very automated instruments, and there's also areas of the lab that are almost completely um, have almost no instrumentation. So you can kind of pick and choose what is you find the most interesting. The lab oftentimes is kind of divided up into 4 or 5 different areas, and often most of the times people start out being a generalist working all areas, and at some point in their career they usually choose something like they really love blood bank or they really like working in microbiology, and they kind of specialize. Um, Most people don't know that the lab is not run by nurses. I think they always assume it's a nurse or something that's doing that. And we are very specialized in Montana. You have to have a special licensure. Um, I don't think there's a lot of awareness of that those jobs are out there. There's uh, there's also like in pathology, there's people who are histotechnologists and cytotechnologists also. That's just another offshoot of the lab that I don't know a lot. There's some amount of things you can do with training on the job, but most of the time you go to a specialized school for that, and then work in a clinic if you're interested in clinical laboratory.
Awesome. And real quick, just to follow up on that, there's like a little discrepancy that I was kind of unsure of, and I think might confuse some other people. Is there a difference between clinical laboratory and medical laboratory, or are they the same thing?
I would say they're the same thing. I mean,
Okay.
you could clinical means that in general, clinical laboratory means that you're working on human specimens for diagnosis, as opposed to research or, there's veterinary, there's any number of other areas you can be in, but for the most part, I would say clinical lab is pretty much assumed to be human-based diagnostic.
Okay.
Yeah.
Awesome.
And Jack, there is a distinction between like clinical pathology and anatomic pathology.
Okay.
Most community pathologists are board certified in both. And so, as far as like a postgraduate residency training in a specialty, whether it's family medicine or general surgery in pathology, it's the program is generally 4 years to do both. So it's 2 and 2 for
Mhm.
clinical and anatomic pathology. And like Jen said, I don't think there's a difference between clinical lab and medical lab. I would say though that in the clinical lab, you're dealing primarily with kind of non-tissue based specimens. What I mean by that is that in the anatomic pathology lab, we use microscopy um, at 95% of the time or greater for making our diagnosis. And the microscope is kind of the main instrument. In the clinical lab, we have a variety of instruments that I'm not even close to being the kind of expert that Jen is in terms of how they run and how to keep them running. But um, there is a bit of a difference in terms of specimens. They, I think, see a lot more testing than we do in the AP lab. However, as a pathologist that's clinical certified, clinical pathology certified, I'm quote unquote the kind of the medical director, and so I sort of function almost as like a liaison between the physicians in the laboratory because it's a highly specialized area, and you have to kind of translate for doctors a lot. And lab techs do that all day long too.
Awesome. Could you, Dr. Loom, could you go into like pathology a little bit? Kind of like what you guys do? Because I've heard a lot about microscopy. I have heard postmortem exams. So can you tell me a little bit about like broad range pathology and then talk about those two like
Sure.
specific?
Maybe I'll tell you what kind of my day-to-day work
Mhm.
uh, life is like. So I come in between kind of 7:30 in the morning. I receive a variety of sort of a stack of slides throughout the day. Let me pull one to show you. So I got to cover up the name, but can you see this? This is a glass slide with tissue on it. And so this is what I put under the microscope and look at. So in this particular case, it's a biopsy from somebody's tongue. Um, so we get a variety of specimens coming from clinics, the operating rooms, different parts of the hospital. And so the tissue comes in, from these places and it gets processed here by in the AP lab. So we have pathology assistants, we have histotechnologists, we have cytotechnologists, we have a variety of techs that are basically processing the tissue. So it goes from the patient's body on eventually onto a glass slide that I can look at. So most of my day is spent looking through the microscope, um, either doing um, cancer screening, like looking at pap smears for cervical cancer screening, or gastrointestinal biopsies to look for colon cancer, or breast or prostate biopsies for screening for breast cancer or prostate cancer. Um, and then we also get bigger specimens. Usually, once a patient has a diagnosis, say for instance a prostate cancer, and they have to get their prostate taken out, we have to stage the cancer, in which case it turns into many more slides because we have to look at several parts of that actual organ under the microscope to determine like how big is the cancer, how far is it spreading, is it involving other structures in the body like the nervous system or getting into the blood vascular system, things like that. So that comprises kind of the bulk of my daily work. I try as much as possible to get down into the clinical lab. I'm lucky to work with amazing people down there who are very smart and very caring and do a great job. So I can trust that all of that other testing going on is being done correctly and efficiently. Um, because it's a huge operation. And we all have big parts to play in it, but that's kind of my work on a daily basis. So I generate reports when I look at tissues and kind of type them up, and then those get signed out by me and are available to the patient and to the physician to look at, and that helps them kind of move on to the next step in the patient's care.
Awesome. That was like a super comprehensive answer, and I think it might have answered some of my later questions too, which is great. Um, Let me just see here. Yeah. So, okay. Um, Now that I've heard a little bit about your guys' careers and what you guys do in like the respective conditions that you work in, can you guys tell me a little bit about the education it takes to get into each position? I know you guys have both touched on it like briefly, but can you guys talk about like what the degree requirements and certifications, maybe talk about some like other careers in the area that you guys work that are might be a little bit more entry level that somebody interested in the career could maybe work in and see if they really like that area of like healthcare?
Dan, you want to go first?
Sure. So in the clinical lab, I would say if someone is interested in this field, um, learning to do phlebotomy or be a lab assistant would be a really good way to see what happens in a lab without needing necessarily a degree. Phlebotomy is probably as far as the clinical lab is concerned, we do most of our testing on fluids that come from the body. So our phlebotomists are very, very important. And they're also what people see is part of, that's who they think the lab is. So it's a fun job. You get to see a lot of different things. It's a hard job. You're taking blood from people most of the day, which most people don't enjoy. So you have to be really good with people. Um, Lab assistants basically take the blood from the phlebotomist and then process it so that we can do the testing on it. So those two jobs are we always have positions open. I would say probably most hospitals do, or even clinics. Um, it's a really good way to see what the jobs are without necessarily committing yourself to them completely. People who decide to be clinical lab scientists usually here tend to get a microbiology degree, so a 4-year BS degree in microbiology. Um, I think as long as you were in the sciences, biology, chemistry, or any combination of those, you would be good. Usually, you have to have statistics, a little bit of physics, but then mostly biology, chemistry. And then you need to apply for and be accepted into we call it an internship that we do a year after you've gotten your degree, whatever it is. Montana State does have a clinical lab science program, but bigger colleges, universities all probably have the same thing. And you need to, like, we take students here and we take them for not quite an entire year, and we train them in all areas of the lab. And then once you've done that internship, which is generally unpaid, then you take a national certifying exam. There's several that you can take, but the most common one is by the American Society of Clinical Pathologists. And that's recognized not only in the US, but around the world as a certification. So once you have that, you're basically you are able to work in a clinical lab. In Montana, we have a licensure, so you have to have that background in order for you to work here. Some states might differ a little bit. Military might be a little different. There might be a little bit different ways of going about that, but in general, that's the pathway most people follow.
Awesome. Your turn, Dr. Loom.
So, yeah, it's a long pathway, but nevertheless, yeah, I mean, I think in any field that you, especially in the healthcare field, the basic, I think, philosophical starting point is that, if you want to help people, this is where this is the area that we all chose because we wanted to help people in one way or another. Fundamentally, you have to go to a four-year college, achieve a bachelor's degree. Medical school, it's been over 20 years since I started medical school, so the requirements may have changed, but when I was working towards it, you did not necessarily have to get a Bachelor of Science degree, but you did have to complete your pre-medical coursework. So that was 2 years of chemistry, like a general chemistry year and an organic chemistry year, a year of biology, a year of physics, and generally up to at least, I think, a semester of calculus. I had to sit for the medical college admissions test, the MCAT. And then, I actually applied through 2 cycles because I did not get in the first time. But during that time, I got a job at the hospital. I was working, like I said, at a mental health clinic for refugee populations in Portland. I also volunteered at the hospital. So I was working with medical assistants and nurses on a surgical floor, turning patients and running and doing things for patients and nurses. So as one nurse put it when we were changing a patient, she's like, I think every aspiring med student should do this. And so at any rate, you kind of have to show not only that you have the intellectual horsepower, but the interest and the commitment to working in this field. Um, so once I got into medical school, it's 4 years. The first 2 years are classroom based. You do shadow doctors. I had opportunities to work in a family medicine clinic. I got to shadow a cardiothoracic surgeon. That was pretty awesome. I remember that was at that point, I was like, I think I want to be a surgeon. And the second 2 years of medical school are your clerkship years. So the third year is actually called your clerkship year, and that's where you do about I think it's about 6 to 8 weeks through different departments in medicine, whether it's internal medicine, general surgery, obstetrics and gynecology, psychiatry, pediatrics, things like that. And then in your fourth year is when you kind of tailor your schedule to what you're interested in doing. So a lot of students say who want to go into pediatrics will do some additional rotations in pediatrics. There are other rotations that you have to do, like through emergency medicine. It's been a while. I was trying to think what else I did. I had kind of a variety of rotations. For instance, I did a month of plastic surgery. I worked with a hand surgeon, so I got really good at sewing and suturing up wounds, which was great because the next month I was in the emergency room. So anytime somebody came in with a big laceration, they'd be like, "Oh, send that med student Loom in there." And then I would, sew these wounds up really nicely and people were pretty happy about that. So it was fun to be able to do that. But during that fourth year, you kind of have to start applying for residencies. And depending on what specialty of medicine you want to go into, it could be 3 years, like pediatrics and family medicine, or it could be, 7 years if you wanted to be a neurosurgeon. So you kind of you have some major decision points in medical school. One is like, do I want to cut or not to cut? That's one fork in the road. Do you want to be a surgeon or do you want to be, a clinical physician, like a pediatrician or an internal medicine doc? And the other was like, do I want to do, diagnostic medicine like radiology or pathology, or do I want to do clinical medicine? So, for instance, like I don't see patients. I see them. I know when I'm looking at a glass slide that I'm, someone's depending on me um, to help them, but it's a little bit of an abstraction, right? So I'm not looking them in the eyes. I'm not kind of giving them bad news face to face. That's very difficult. Um, and it's not that I don't think I have the appropriate social skill set to do that, but it's a hard part of being a physician, dealing with people when they're, going through this emotional roller coaster of dealing with illness. And it takes a lot of energy to be able to do that. And that's why burnout is a big problem in medicine. So, this concept of a work-life balance is kind of a very modern idea, when I was a surgery intern, it was right when they introduced this 80-hour work restriction for residents. Because prior to that, you would work you nonstop. Like, if you wanted to be a, board certified general surgeon or emergency room physician, you worked all the time. And so they restricted it to 80 hours, which, has good things and bad things about it, but I won't go into that in too much detail. But at any rate, residency is kind of where you get your specialty training because you finish medical school with a medical degree, but you can't practice medicine without a board certification in a particular specialty. So when I went through the Navy, I did an internship year. I was certified as a general medical officer. So I actually did primary care, but I was in a clinic with other physicians. So if I had something that was too complicated that I was struggling with, I had a lot of help. But I was also taking care of 18 to 40-year-old males who were otherwise perfectly healthy. In fact, I spent most of my time in the Navy probably doing mental health counseling more than anything else. Um, so that's kind of in a very broad and general sketch of the pathway to becoming a physician. There's a lot of tests involved at various stages. I kind of think of it as like waiting in a long line at a roller coaster at Disneyland. You think when you go through that door, you're going to be getting on the ride, but then you go through it and the line keeps going. So you have to be patient, you know, and realize the ride isn't going to be, 2 minutes long. It's the rest of your working life, essentially. So once you're there and you're busy working, you're glad you made it. So,
Yeah, thank you. That actually, I think there's a lot of misconceptions, I think, in the as far as the pathway to becoming a physician goes, and like at least high schoolers, and I think a lot of undergrads too have a little bit of a misconception as far as that pathway. So I think it's a nice thing to be able to kind of have that picture drawn out a little bit by somebody who's gone through it and has gone through a long version of it and seen so much and gotten so much experience. I think that's very beneficial for the people who
yeah.
watch this. I think it'll help them a lot.
Jack,
Uh,
I would add to that though that another important decision that people make in their pathway is whether or not they want to have an academic career or a community-based career. So I was not interested in doing research for starters. Um, so a lot of my fellow medical students, they stayed in academics or at big institutions and they're doing research. That's part of their kind of work obligation. They have a clinical side, they have a research and a teaching side to it. My job is purely clinical. Like I'm just looking at slides, helping make diagnoses and helping, make sure the lab is working. I don't necessarily teach. Once in a while I do when we get students through the WAMI program that come by who are interested in pathology, but I don't have research obligations. And for that, I'm very grateful.
mhm. Would you say that like delineation occurs when somebody pursues an MD PhD or just in general when they pursue their MD?
Well, if you're going the MD PhD route, you definitely are kind of on an academic trajectory. So generally, those are med students who have already had some research experience prior to starting medical school, or they have a particular area they're interested in, whether it's like infectious disease or biochemistry or what have you, So they will, I think once they've accomplished the MD PhD, they have the ability to have kind of a dual career in research and clinical medicine. But I have met people that have achieved an MD PhD and then they just do research, or they decide they're going to just kind of focus on clinical stuff. But they have a strong research background. So, you know, it's um it's a great field. There's so many different ways you can go. It's kind of mind-boggling, actually.
Awesome. So now going a little bit into those pros and cons of each career, I kind of have like a specific question that I just want to hear about, like the general pros and cons for each of you. I just like the general question is also pretty broad. So for you, Dr. Loom, what are some of the challenges you faced as a pathologist and how do you like generally navigate them? Is it like workload or like specificity or is everything super broad? You know what I mean?
Um, yeah, I mean, that's a good question. I think the challenges for me kind of change over time too. Medicine is something that if I wanted to, I could work all the time. There's no end to the amount of work that needs to be done. So you kind of have to be able to take care of yourself, and know your limitations. I mean, it's just kind of, I've looked through a microscope for up to 12 hours, and I know that was when I had to as a resident. But now by, hour 8 or 9, my eyes get tired. So I feel like, I'm more likely to, it's a little bit risky. I don't want to make a mistake. I don't want to misdiagnose something. So I have to recognize like, okay, this is a hard case. I'm starting it at 4:30 in the afternoon. I think I need to give myself a little more time and look at it first thing in the morning, So it takes a little bit of self-awareness to know, um, when you're at your best and when you need to kind of pull back and maybe, go home for the day. Um, there's always challenges in medicine in terms of the reimbursements too, getting which are often being cut year after year. So um, but nevertheless, I'm still going to work as hard as I can and try and do right by the patient because that's what I was called to do when I decided to do this in the first place. Um, I'm very grateful that in the field of pathology that I probably do have more time than a lot of physicians in the sense that, I get to go to my kids' ball games. I'm a scoutmaster here at the local Boy Scout troop. So, my life is extremely busy, but it's busy in a good way. I'm busy at work, but I also get to do a lot of things outside of work. Um, And that would be, I think, harder if I was in an academic position where at the end of a long day of clinical medicine or clinical pathology work, I have to work on a research project. Um, that's kind of why I'm glad I'm out in the community and not at a academic center. So those are some of the challenges, I think.
Awesome. And then for Jennifer, what are some of the challenges of managing a lab team and like ensuring that everything gets done correctly? I mean, obviously it's a pretty high pressure environment, I would assume. So like what are some of the challenges involved with managing a team and like as large as you manage and like with as vast of like a workload throughout the day as you manage and variable? If you That was kind of a convoluted question, but do you understand what I'm asking?
Well, I would say um, our challenges would be staffing.
Hmm.
We actually are kind of a like I mentioned before, most people don't know what we do. So to actually find people who are qualified, um, and to be able to keep them, like in Bozeman, it's expensive to be able to keep people who are have the experience to do what they need to do can be a little challenging. But in general, everyone that I manage, they're really from top to bottom are high performing people. That's who go into this field. Most of the time, they don't need a lot of supervising necessarily. They're just that type, the person that goes into this field. They're just very self-starting people. They are um, hold themselves to a very high standard. It is not something, I'm just, I feel like my job is to be here if they just need to like bounce a idea off of me or something like that. But I certainly don't manage necessarily what people do. Mostly we just have to have the right staffing at the right time to get the things done in a timely manner. I would say in Montana, it's a little harder in rural communities. I feel like there's the people who do lab work tend to be now people, there's less younger people going into it. So a lot of the communities have people who are going to be retiring and no one to replace them. It's not necessarily, like I said, not people don't know what we do. And in the rural communities, a lot of times you work a shift and then you take call. So your time isn't your time necessarily. But people go like Dr. Loom said, we go into it with the idea that we're there for the patients. That's what we're there, our ultimate goal is to be able to help patients. So people are willing to put up with a lot um, in order to do what we need to do. But I would say probably Bozeman isn't as bad as some of the small communities that really do need their hospitals and really do need their labs. But I would say in the next probably 10 years, they're going to have a hard time with staffing. And probably we haven't done a very good job of getting the word out of what we do. Um, so I would say most people who go into lab work are generally people who have a 4 point plus GPA. They would be really good in a lot of things, but they chose not to necessarily be patient forward. They want to be behind the scenes doing what we need to do for the patient. And it's a very, every doctor uses lab work every day to diagnose a lot of things on patients. They couldn't do what they do without us, but we like to be behind the scenes more. So we're not necessarily probably a hard thing being a supervisor in a lab is realizing that most of the other parts of the hospital don't necessarily respect what we do or know what we even do. And we just don't have a good way of getting that information out there sometimes. But as far as managing, it's people who really, really work hard and they're probably on me more than I am on them. So,
Awesome. That's actually like I feel like that's like having I've worked in a few different environments and they've all been like vastly different, worked with different individuals like adults and kids, and I could work in pretty much any environment if I enjoyed the people I work with. So it sounds like you guys kind of have that, which is really nice.
mhm.
Um, so for host of this year, one of our big projects, our statewide projects, is we're focusing a little bit on cancer education, cancer awareness, like broadly. And so I'd love it if you guys could both talk a little bit about um your respective roles in the cancer treatment slash like diagnosis process. if that makes any sense. I'm starting to move a little off script. Some of my questions are going to get a little bit more like, I don't know, like convoluted, possibly. So if you guys could both talk about that a little bit, that'd be amazing.
Yeah.
Yeah, I can start. So as a pathologist, like Jen was saying, I'm a physician, but my job is really behind the scenes. And it's primarily doing cancer screening and cancer diagnostics. That's a lot of what anatomic pathology is. So for instance, we participate in weekly tumor boards with oncology, radiology, surgery. So all of these physicians and the ancillary staff, nurses and social workers get together to go over a handful of cases where we review, the diagnosis, where that's where radiology and myself show the case. The surgeon will talk about whether or not it's, surgically feasible to remove the tumor, or the oncologist will discuss types of treatment for follow-up if the patient has surgery. That's kind of part of the accreditation process for a hospital, is to have a multidisciplinary tumor board, and those happen in most hospitals. And they usually happen, on a rotating basis, often as frequently as every week. But that's, only an hour. There's preparation time where I have to kind of review all the cases again. Um, but that is an important part of kind of my role as this team of physicians taking care of patients with cancer. Um, but most of the time I'm just kind of like screening things, and so a lot of, most of what the tissue I see does not have cancer. And so I'm providing the information to the physician so they can turn around to their patient and say, okay, your colonoscopy was normal, your pap smear was normal, your prostate biopsy, doesn't have cancer. So most of the time, what I'm looking at, I'm ruling it out. Um, so there's more I can say, but maybe I'll let Jen talk.
Well, on our part, I would say we hopefully people are going to their primary provider, that someone who is seeing them, maybe yearly and watching them. We have basic screening tests that most people get done fairly often that can catch a few things cancer wise once they've been diagnosed. We have quite a few different kinds of tests that are available to physicians to follow their treatment, to make sure that possibly medicines that they're taking aren't causing other problems with different organ systems. And to then, once they've been, say, treated, we hopefully continue to follow them with those same kinds of tests, maybe for the rest of their life, to make sure that that cancer hasn't returned. And if it has, we catch it early and they can do things to help that patient. But we're not very often the initial diagnosing area. That's usually where Dr. Loom is in the pathology department, but there are quite a few cancers that we can catch also that a lot of times are not expected, particularly the leukemias and that kind of thing, where they are maybe just coming in and they're just tired or something on that level that we along with the pathology department, we would say, oh, this looks like this is this kind of a disease, and we confer with the pathologist and move on from there. But I'd say I don't know that they couldn't diagnose cancers without us, really.
Yeah, and I think that was kind of one of the big goals, not just specifically with cancer, but with this specific interview was to kind of show like a given insight into like the diagnostic part of medicine as you guys were talking about before, and show people because I think that you guys it's unfortunate but true that pathology and lab do get like I think broadly overlooked, and it's almost it's a shame because they are such an integral part of medicine just across the board from and basically any kind of disease. So that was it's a it's good to talk about, I think, these kind of things because it gives a little bit of insight because people think they want to go into medicine and they might have a misconception that a certain responsibility is associated with a different career, and then they spend a long time pursuing that career just to realize it's not really the one that they wanted.
Mhm.
Um, moving into my last section, I just want to talk about like a little bit about like technology and trends in both your guys' careers. And so I have two questions. They kind of go hand in hand. The first one is how since the beginning of your work has technology changed and become more advanced and helped make the process faster, make it easier, make it better? And then are there any emerging advancements or trends that you guys think are you like specifically excited about or think are like going to be very beneficial?
Well, I can tell you from my long career, it used to be very manual. I would say it was as good as it could be at the time, but very manual, which means there's a lot more room for error, a lot less reproducibility in testing. Now we are very, very automated. I would say we have so many checks and balances that we have very little downtime. Tests are always available. That we guarantee basically that the results can be trusted. And we have, I would have said maybe in the last 20 years, just grown leaps and bounds and the things that we can do that small labs can do that used to be maybe only in the large teaching hospitals is available to even this very small rural labs. And probably the direction that a lot of things are going is, or where the big growth would be, it'd probably be molecular testing. That never would have been available to even a lab our size not that many years ago, and now we have so many things available to us, and so many things are going in that direction that that are very specific and really I think lead to very quick, accurate diagnosis of different diseases. So yeah, it's kind of we used to basically be a tin can and a string, and now we're like what smartphones are like. I mean, it's been that fast and that incredible, really. So on the and at least in the clinical lab part.
Yeah, I agree with Jen. I think the molecular aspect of medicine has really changed a lot and revolutionized, diagnosis and monitoring for certain diseases. When you think about it, like when I mentioned kind of the traditional stereotype of the pathologist as being, in the basement, surrounded, in the morgue, basically. It wasn't that long ago where, patients would die in the hospital and it was really not clear what the cause of death was. And the postmortem exam was kind of the tell-all and often, necessary part of coming to the diagnosis. But nowadays, with the advances in imaging, radiology, diagnostic testing, it's not so much a mystery why people are sick or why they're dying. So the postmortem exam is kind of, really not that useful as a think of it as a diagnostic test, right? Like coming to an answer about, with the central question, what is the cause of death? So like my job, has changed quite a bit, not necessarily in my lifetime, but over, the last 100 years in terms of what I do on the daily. So like I said, I'm looking through a microscope. So that still is the kind of core of my work. But, I make a diagnosis not just with histology by looking at tissue, but I have to incorporate molecular data and cytogenetics. In the field of hematopathology, we have our classification system from the World Health Organization. I keep this book on my desk because this is the Bible of what I practice every day. And the diagnostic classifications for leukemias and lymphomas require molecular testing. So it's you have to incorporate all this information, not just what I see through the microscope, but what kind of the cell cultures grow and what the DNA tests and other assays show. So all of this, there's just all this information, and we have to know how to kind of incorporate it into the making the diagnosis. But that also allows doctors to monitor patients a lot more closely. When someone goes into remission from their cancer, they would have follow-up imaging, and maybe that was it, a clinical exam and a history. But now they can do serologic testing, looking for circulating tumor DNA and things like that. Um, so it's pretty amazing, and it's also revolutionized therapeutics too. So, and then you look behind Jen, you can see this automated system in the lab. That wasn't there when I started. 7 years ago. It came in like the following year, um, but had been a part of the planning process, I'm sure, for many years before I started. But maybe you should talk a little bit about what that actual automation line has done for the lab in terms of technology, Jen.
Well, we do have a very, very automated system. Part of that allows us to do a lot more testing than what we used to be able to do. It speeds up the testing. So especially with the emergency room or the operating room, we can get results out much quicker. We need less people to do more work. And it's because it is so technically advanced, I guess you could say, we can count on the fact that it will always do the testing the way we expect it to. So we never have to worry that the pipetting will not be correct, or it won't know what test to run, or it won't run the test that is asked. It's very advanced. So it makes us be faster, more accurate, and we can 100% count on the results that we get. So that would not have been the case, 30 years ago, for sure.
Awesome. That is pretty much all the questions I had for you guys. Are there any other insights into the field that you guys think I haven't highlighted that are important for people to know about, that you think should be highlighted at all?
Well, I would say lab work is pretty cool. Pretty much we touch on almost probably 100% of every patient. Any patient anywhere pretty much gets some kind of lab work done.
Mhm.
And that if people are interested in it, in any field, the best thing you can do is kind of call up a local, hospital lab or pathology lab and say, hey, could I come and see what you guys do? Most people are thrilled to show people what they do. So I know people here would really like that. We have to go, get permission and that kind of thing. But if people are interested, they should definitely check it out and see what goes on.
Yeah, I would agree with that. I would also say, Jack, that I'm learning new things every day in my work, which is good because I love to learn. And I think if you're very curious and you're interested in medicine, you just sort of follow your curiosity and see where it leads you. Like I said, I didn't intend to end up where I'm at when I started, but I just kept following the things that interest me the most, and that's how I got to where I am today. And like I said, medicine is a field it's growing outward at an exponential pace. You have to be willing to continue to learn to be able to do the jobs that we do. But that's also what makes it fun.
Awesome. Thank you guys so much for joining me for this interview and like being a part of this project. I uh I came up with this project this year like with the hope that it would kind of help highlight careers that get overlooked that I think are very influential in the healthcare process. And so it's really meaningful that you guys made the time to come out and onto this interview and do this.